I want to welcome you now to something to talk about. Loren Bast is joining us as the Executive Director of Bainbridge Prepares, because we're going to talk a little bit about vaccines. And I know that it's possible Dr. Cowen, David Cowen, will show up. He's the director, I believe, of the Medical Reserve Corps, part of the coordinator effort of that, which has been hugely responsible for the vaccines and boosters that this community has gotten over the last year. I think it was December of 2020 that the first vaccines were given out. And in addition, the city and the Bainbridge Island Community Pharmacy were all part of that. But it's like Groundhog Day, Loren. I mean, here we are 1 year later, and people are as nervous as they were a year ago, and people are standing outside of the pharmacy hoping to get a booster, just like they were standing outside of the senior center hoping to get the first vaccine. This has got to be pretty crazy for you.
Yes, it has been. And by the way, you all are lucky that I jumped in. I'm the better guest anyway versus David. So and when Reed emails me, I jump. I just like Reed takes priority in my book. So yes, I think with everybody, I keep wondering if we're turning the corner and we can all get out of this business and return to real life. There's a bunch of good news and a bunch of not so good news. But I guess I'll start with it has actually been 1 year exactly today that we did our first vaccinations outside of the Winslow pharmacy at Bainbridge Island Community Pharmacy. So fast forwarding to today and kind of where our status is. So I'll talk about vaccines, but I'll also talk about case counts, because just so you all are aware, we're kind of going through a little bit of some outbreaks on the island. Kitsap Public Health has shifted to a once a week updating of our case counts versus the every weekday that they used to do as early as a month, or as recently as a month ago. And if you look at their case counts today, we, for the first time that I can ever remember, we being Bainbridge Island, leads the county in terms of case counts per capita. So, we're used to seeing South Kitsap or Bremerton or whatever kind of leading the way, and we were kind of clean thanks to a lot of people on this Zoom session, thanks to everybody being safe and getting their vaccines and all that. Well, we are going through some outbreaks right now that seem to be stemming from kids, teenagers. The high school has had a number of outbreaks that are appear to be due to wrestling matches that happened earlier this month. It wasn't just our school or our school district affected; it was a number of other school districts around the state. But it seems like that those spread out and got other kids infected and parents and all that. And so we're still trying to kind of damp down those fires. But the way we do that is through vaccines and safe measures like masks and all that. And so in terms of vaccines and the plans for those, I know a number of people are having trouble getting boosters. We did our last clinic of this year a little over a week ago, last Saturday, and we knew that we could have done another full clinic of 1,200 individuals, but we just didn't have the space available on both of those days. And so our next clinic looks to be planned for January 8th. I know that seems forever away. Unfortunately, that's just kind of how it is. And in the meantime, you might have to be standing outside in the lines at Bainbridge Community Pharmacy if you or somebody that you know needs a booster between then and now. They're doing about 60 to 80 individuals walk-ups a day, and they are just busy. So,
and this is true. This is true at a number of pharmacies around the region. There are some places where you can get a appointment, but they are usually booked through the month of January at this point, and so the walk-ups are pretty common. So now what we know, I don't know whether you've had the occasion to talk with the Kitsap Public Health folks directly, but we are getting information now that was posted today that's 5 days old, and I'm guessing that those kids with the wrestling and other kids that got infected have been busy accidentally spreading that virus over the last 5 days. So we can expect that the number of somewhere around what, like 38, 40 cases is probably much higher than that right now.
it probably is. That now Bainbridge Island School District did a very good job of testing. They have their own testing drive-through that's somewhat unique to Bainbridge Island, to any school district. We're one of the few in the state to have it. So they were really good about testing any close contacts of those, of those kids that were known positive cases. But we know of other instances where we're actually going to be going through, with Kitsap Public Health's help, testing of potential large outbreaks through, like, let's just say holiday shows, for example. We know of a few positive cases that have come out of those, and so we're testing all close contacts and parents and all that today. So I would anticipate those numbers are going to rise, unfortunately. But it looks like, oh, there's David. It looks like hopefully, if it, in terms of the possible good news, is that if it's Omicron, which it probably is, those cases are going to be relatively mild. No case is super mild. It's not like you want it, but if you catch it, chances are, if you're vaccinated or boosted, you're going to be okay. So
I would like, I was going to ask you about testing and what the possibilities are, because that's the way to kind of catch this, to see if there are people who, and tests, although the president is promising 500 million of them, are unlikely to be here in bulk next week, right?
That's correct. I mean, so Biden's announcement, while very welcome, it's going to take a number of weeks to roll those out, and it's not like 500 million tests are going to be delivered on everybody's doorsteps tomorrow. So we're kind of be scraping by until those happen. And if you think about the just sheer numbers, 500 million tests spread out amongst 350 million Americans, it's not as many tests as it sounds. So we're going to be looking to supplement any way that we can.
So David, thank you for joining us. David Cowen you're the director of the Medical Reserve Corps, with Andrea Chimey helping as a coordinator. If you could unmute yourself, I'd like it if you could just spend a couple of minutes telling us what you see as we look at what looks to be maybe not as potentially deadly of a virus, especially for people who are vaccinated and boosted, but is certainly a contagious one, the Omicron variant.
And I am sorry that I'm late and that I missed what Loren said. The part I caught about what both of you have been saying seems correct, that it does look like this strain is contagious, and the amount of protection in terms of becoming infected with Omicron, the amount of protection one gets from prior infection or from vaccine is a little bit unclear. It certainly looks to be partial at best. Most of the cases that I'm seeing are in younger people, although they probably are doing more activities that put them at risk. But many of the younger people that I'm seeing are vaccinated and boosted, and in a few cases even had prior infection on top of vaccination and boosting, and are developing symptomatic confirmed COVID. So that is somewhat concerning. So far, and this is anecdotal, the cases that I've seen can be traced back to unmasked face-to-face activity indoors.
Yeah, we were talking earlier about a wrestling team that was at least one part of that outbreak, but there are probably other cases as well.
And I assume that they were unmasked when they were wrestling. So that continues to appear to be, to be the high risk exposures. And so far, I'm not seeing, things that really didn't happen prior in the pandemic. People getting sick wearing a mask at work, for example, or I just haven't been able to identify any masked infections. So the mask, I think, still provides reasonable protection as long as the other people are masked. But for what I'm telling my patients is that for the holidays, unfortunately, I don't recommend unmasked activities certainly with anyone that you really don't know intimate details of their personal life and immunization status, and really beyond that, if you're over 65, really everybody probably should be testing if they're going to have an unmasked indoor gathering. And it sounds like you were kind of wading into what is that? How do you do that? And it's the holiday is poorly timed this year versus.
That's a gentle way to put it.
I think the president would have been better off just postponing Christmas until February.
I could see some political hay being made out of that.
Yeah, that might not go over well. So I think he did what he could, but the Christmas is when it is, or the winter holidays are when they are, and we're just gonna kind of have to deal with it. But again, for people over 65, who I would think would be the main audience here, I stand by my prior advice, because I think that there just isn't enough data on Omicron, for me to feel confident that it will be just as mild in my over 65s as it appears to be in my under 35s.
Yeah, and the thing that does seem clear is that vaccinated and boosted, you can certainly still contract the disease, and so it's more a matter of how robust your response is going to be rather than whether you deal with it or not.
Yeah. I mean, I think that the whole spectrum of disease is still possible, even in people over 65. There are certainly younger people who have so-called asymptomatic infections. They're only detected because of workplace testing or other testing that they're undergoing. Or sometimes it's just caught very, very early by the workplace testing, which is great because that means that they stay home. But at best, even for these younger people, it's 10 days of isolation from the first symptom, which, certainly by this point includes Christmas and New Year's, basically in your own room at home, not venturing out of the house and not probably venturing out of the room unmasked.
So you have said that most of the cases that you've seen in the young people, which is mostly who you've seen, have been relatively mild. Is that right?
Yes.
And what have you, because I know that you pay attention to this more than just your own practice. You've been interested in this from the start. we talked about having this conversation a couple of weeks ago, and you thought that we would have more information now after some of the research and some of the information was starting to be spread around the scientific and medical community. Do we have any insight? I noticed, in the paper that it looks like perhaps South Africa's outbreak may have peaked, so this may not be a long-term trend, this particular variant, even if COVID is with us for a long time. But what do you know?
I don't really know more than, what's in the papers. This is so fast moving that I would say it's out in front of the science. I mean, my wife, who runs a business here on the island, she's been watching the Kitsap, public health statistics, and she says, "Oh, well, those haven't moved at all." And I think it's because they only update them now, like once a week or something.
Once a week, and the data is 5 days old. So
right.
What you're seeing in your office is a lot more current.
Right. And what I explained to her is, well, with a virus that looks like it has a case doubling time of every 2 days, a once a week update from the public health department is not going to be even remotely close to adequate to making decisions about what's actually happening. That's definitely driving in the rearview mirror. So
what do you?
I would say it's just compounded by the rapidity. I think that the Delta variant might have been somewhere between 3 days and 5 days of doubling, or 7 days. And the prior variants before that, it was like several weeks to get to double the number of cases. So, I think we just didn't build an information infrastructure that can go at that speed. And so it's very hard to make forward-looking projections. But I think that what you mentioned about South Africa is perhaps a reason for some hope. The fact that the hospitalization rates, even in New York City, don't seem to be skyrocketing from COVID. That's a hopeful signal. And I think that the drug that was approved yesterday, so my timing was pretty good. The 2 drugs that were approved yesterday, I really think are going to just change the, to me, I mean, it's, obviously predicting the pandemic has not been very easy for the scientific community, and I'm not, Dr. Fauci. So, take this for what it's worth. But to me, I think those drugs, when they are combined with readily available testing, and assuming that the drugs themselves are readily available, to me, that seems like the end of the pandemic. And I can flesh that out if you want me to.
That would be great. Yes, please.
So, the Pfizer drug in particular, the Merck drug has some properties that I think are going to make it a little bit unappealing for mass use. But the Pfizer drug, as I understand it, is a reverse transcriptase inhibitor, a class of agents that we have a lot of experience with from AIDS drugs. And it inhibits the virus's ability to kind of replicate and chop up its replicating RNA into pieces that can then be transcribed. So it can be quite effective. I think it really only affects the viral reverse transcriptase, so it doesn't have very much effect on the person. And although the study that was used to, it was the basis for the approval by the FDA, was quite small, I think about 375 subjects, the results, were very compelling. 90% reduction in, this was in unimmunized patients, 90% reduction in hospitalization. And I believe in the study group, there were 0 deaths out of 375. And in the control group, another 370 some people, there were, I believe, 10 deaths. So I think that's quite compelling. Now, obviously, it may not be quite as miraculously effective as that, but even if it's anywhere close to that, even if it was half as effective, that would be a game changer.
And at this point, it's approved for people who would be immunocompromised or elderly and therefore immunocompromised. So the people who are at most at risk of dying are the ones who are going to be the first ones to get this this treatment, probably.
Because it looks like it will be in short supply, for quite some time. And I think that's where the Merck drug may come into play. For people who are really at very high risk, the Merck drug might be also appropriate. And it does unfortunately look like it's going to take several months for Pfizer to ramp up the production to the point where, that anyone who gets COVID could go and fill the prescription. The estimate I saw yesterday in the Times was March for a more plentiful supply. The supply looks quite restricted until then. So, we may have a couple more rough patches here.
Right. So just in terms of behavior, you talked a little bit about the holidays. I'm guessing that your advice for seniors is to obviously be boosted. And if you're going to hang around each other, wear a mask if at all possible, maybe two.
I mean, I still am enthusiastic about outdoor gathering, although I recognize it is the winter solstice. But, where that's not practical, wearing a mask, yes, indoors, ventilating the space makes a difference. All those things really make a huge difference. And, again, I'm hoping that there really will be more detailed epidemiologic data. I'd hope that we would, know a little bit more about, contagion, how does the 6-foot rule and a regular medical mask, is that still good enough? But I just don't think we have that yet. So I think erring on the side of caution for, people who are older or who have some chronic condition, particularly an immune condition. A lot of other things don't seem to be. For example, I was surprised to read recently that asthma was not correlated with increased deaths from COVID. I think it was correlated with an increase in hospitalizations, but there was not a statistically significant increase in deaths. So that was, I guess, better than it could have been, and not what I would have expected. Thinking that people with asthma and other maybe chronic lung conditions would be more prone to complications.
David, if it's okay, I'd like to invite other people who might have questions to ask them if there isn't anything else that you want to make sure you get out here.
Well, I did want, I'm glancing at the other screen here because I'm trying to find something that I found on my computer at home last night on the FDA website, which is, I have to say, always a challenge to navigate. But they published yesterday a list or an updated COVID test kind of bulletin, because they are going back and retesting the tests, both molecular and antigen, against Omicron. And I don't think they're done yet, but and I'm hoping I can find the link before we're done. They did say that it looked like the Binax Now Abbott test and the Quidel test, which I can't remember the name of. Those are both antigen tests. It looked like they did. It appears that they tested them with killed Omicron virus. It was too dangerous to do the testing with live virus. So they used a killed version of the virus to protect the experimenters. And both of those tests did detect the killed version. They said they hedged and said, well, we don't know if it will behave the same way with live virus yet. But I think there's some reason to think that those two anyway work. There were 3 that did not pick up Omicron. and there were also several, worryingly, there were several PCR tests that also missed Omicron. So, unfortunately, it looks like hopefully, especially in our region, people are not offering tests that the FDA has already said don't work, but it may require some consumer, caveat emptor.
Yeah. Sheila, did you have a question?
I had a couple, if I might, Dr. Cowen.
Yeah.
So when you're talking about not the asthma, so what about COPD, which is what I happen to be labeled? I happen to have. So was that included in that?
I don't think it was in the study that I happened to see. And the mechanisms of COPD and asthma are slightly different, so I'm not sure we can generalize to COPD. There may be, I have a feeling there are other trials that I just haven't seen yet. So you might want to look in Google on COPD and COVID outcomes, although, yeah. And I would also recommend considering talking to your lung provider or your primary care provider about possible interventions for patients with COPD, in case they do get COVID.
So that would include perhaps one of the two drugs that are coming along.
Of course, it would include those, but it might also include some kind of asthma inhaler, steroid inhaler.
Yeah, I did.
have those already. So, yeah.
I did read that there are some of the monoclonal antibodies that are not as effective as they were against earlier variants.
Yeah, that's also not good news. The two that are most widely available here in the United States that are made in the United States, the one made by Regeneron and the one made by Eli Lilly, are not effective against Omicron. The GlaxoSmithKline monoclonal antibody sotrovimab retains its effectiveness, but is in extremely short supply. It was in very short supply even before Omicron, because I tried to get it for patients and couldn't. All the distribution of those drugs is by the federal government, by allotment to the states, and then the states distribute within the state. To my knowledge, there is no sotrovimab available in Washington state at this time. And yeah, I'm not sure how quickly, Glaxo released a press release yesterday and said they're trying to ramp up production as soon as possible, but there's been quite a bit of demand for that even before yesterday. So, I have a feeling they're going, probably making it as fast as they can. It is not made in the United States.
I have a naive question about that, if I might. I hear the terminology and the names of things, but I don't know what you're talking about.
Right. Okay. So, monoclonal antibodies are special antibodies that are kind of custom made to bind to the surface of the virus and prevent it from attaching to your cells. And up until Omicron, there were 3 that seemed to work fairly well and have relatively few side effects. These 3, of course, are all on emergency use authorization. They have not been studied for a long period of time. The Regeneron product had an advantage of being able to be administered subcutaneously. The others, including the main studies for the Regeneron product, they were all given intravenously, which from a practical standpoint has just been extremely difficult in an overloaded healthcare system. It requires several people, a nurse, an assistant, someone to observe the patient for several hours for reactions. Not all that easy to do in someone's car, for example.
Right, it's the kind of treatment that the former president received, right?
Yes, he received the Regeneron product for a prior strain, but the state, I'm sure, is very quickly going to cease distribution of the Regeneron and the Eli Lilly product because of the lack of effectiveness against Omicron.
I think Richard came with a question. I don't know if you want to ask it, Richard.
Yeah, actually, the doctor addressed it. Good morning, good afternoon, doctor. Which had to do with the pills, the Merck and the Pfizer treatments, which were, I believe they're both approved. When they'll be available. The New York Times was terribly optimistic this morning. Should be available in a few days.
Yeah, I don't see how that's possible. I think if I remember right, the U.S. government has, contracted to purchase the entire available supply in the United States, and I thought it was 600,000 courses of the Pfizer drug for the remainder of this month.
Well, I believe that they could be producing it on the off chance that it would be.
Oh, for sure. No. I
Yeah.
think that the government did a good job and told the manufacturers to just make it and that we would buy it whether it gets approved or not. So that's smart.
So here's the practical question. I think this is a hypothetical. I think I got the vid. And how do I go about getting those pills? Do I call my doctor? You're actually my doctor, believe it or not. You're my doctor of record, even though I don't come and see you. But I mean, it's, you can look it up. I have another doctor for a specialist for other things. I go see him all the time.
Well, I can't give you, medical advice as a public Zoom call, but I would say yes. You should call your doctor. I haven't heard anything yet through, for example, Virginia Mason about the distribution of the Pfizer drug that was approved yesterday. There's another product that was approved, I believe, more than a week ago, I think called Evishield, something like that. Evishield. Does anyone else know the name? No? And that's intended for high risk, like immunosuppressed individuals, say on chemotherapy, things like that. A patient's been inquiring about that, and that hasn't been distributed either, and that was approved, I think, even a couple weeks ago. Let me see if I can just find out a little more about that.
It's terribly helpful that you brought the information that and I've already processed the technical part of the technical nature of it, because once upon a time everybody wanted the Pfizer and nobody wanted the Moderna so much, and I happened to get the Moderna, all three of my shots. And then the long-term studies say, well, actually, the Moderna lasts a lot longer at higher antibodies than the Pfizer. So I don't want to be the guy who walks in there and asks for the Merck because he read an article when he was 27 years old, or read the Merck manual, when indeed the one that has better efficacy is the Pfizer. So I mean, as far as I'm concerned,
I don't think either of these drugs are really going to be available at the Bainbridge Island primary care level, I'm guessing for several months, because as Reed mentioned, because of the short supply, there's going to be restrictions on prescribing them. Probably limiting them to the people at greatest need. I did just post the name of the this AstraZeneca product that was approved on December 8th It's another monoclonal antibody. And it's approved. It's a long-acting monoclonal antibody authorized for emergency use for pre-exposure for prevention of COVID-19.
And I want to just jump in about the idea of, trying to shop for the right medical supplies. I remember when we were first getting vaccines, the right advice was whatever vaccine is closest to your arm is the right vaccine to get right now. And I think that that's still true to some degree. Like, I know that J&J has been somewhat denigrated, or at least seen as obviously less effective in the long term, but in the short term, it was exactly the right thing to do if that was what was available to you. And I think that's still probably true, right, Dr. Cowen?
I would think so, although I did notice something, and it might have been in the Times, about the Merck product approved yesterday, that the government, I think, is intending to restrict that, and they didn't say what the restrictions would be. So I'm not sure that's ever going to be for everybody, but
yeah. And we will learn. I mean, as you said, we will learn, and we will continue to learn. We don't know that much right now. I know it's frustrating to you. It is to us.
Barring some, major unforeseen change in the virus, which is already apparently possible, I think that we could be getting to a point in the spring where people are really not being hospitalized and not dying from COVID for the vast majority.
Nina, did you have a question?
Yes, I do. I'm fully vaccinated and boosted, but I am still very confused about the symptoms. Every time I go to the clinic or have to go to the hospital, I'm presented with this list, and I have a lot of those symptoms. I have allergies, so I have cough in the morning. I sneeze a lot. I have a runny nose a lot. And then I also have IBS, so that goes along with the symptoms. But how do I get by that? What do I do so that?
Well, I think you do probably have to fib a little bit when you're going in. I mean, because really, you know your own chronic symptoms well, and I don't think you have to get into that with the checker at the door. Really, what we're looking for is, is there a change in your baseline? There are a couple symptoms, I would say, that really, to me, when people tell me they've lost their sense of taste or smell,
Yeah,
that one, to me, that's COVID until proven otherwise. And I don't think you should be going inside any buildings if that's the case. But in terms of the other symptoms, I think you just have to kind of gauge, like, is it my regular baseline? And if you're not sure, then it may be prudent to not go in the office, try and do a televideo visit. And then hopefully next month or in ensuing months, if testing is much, much more available and it turns out to be reliable, then, hopefully we can just, somebody who comes to the door and says, well, I'm not really sure, I maybe have a little more congestion than usual and my stomach's a little more upset than it usually is. Maybe we could just do a 15-minute, do a 15-minute rapid test and just make,
okay.
and check you on the spot, but we're just not there yet.
And does Omicron have any particular different symptoms, or are they all the same?
Not that I know of. I mean, the patients are telling me things like, bad headache, a lot of congestion, fatigue, and I think certainly body aches and fever are also in there.
Okay.
David, from my understanding, so again, I'm not the doctor, though I pretend I am, is that the Omicron symptoms, less of a loss of smell and taste, and less instance of high fever. That's from some of the some of the news articles that I've read.
Yeah, I think it's going to be, I mean, that's where the testing really becomes so critical because, yeah, it's kind of a moving target trying to chase these, you know, chase these symptoms. And, you know, they're going to be future mutations and they may also have different symptoms. And I think it's just going to be difficult. I think it's going to be difficult to diagnose COVID by symptoms going forward.
Well, I am very heartened by the idea that we may be getting to a point where we have some tools so that we can live with the endemic COVID going forward, much as we do with the flu. And I do realize that in some populations, we're starting to see sort of infection to death rate that is maybe a little bit more like what we've seen with the flu in the past. And although nobody likes a death rate of anything, we are all facing mortality, and we face risks every day when we get in the car or when we avoid taking the flu shot or whatever. So that's heartening in a way, David.
I think it is. And of course, I do encourage people to get their flu shot as well. And I suspect most of your senior center members have done that. Yeah.
I am grateful for you taking the time out of your busy day to update us, and we will share this around the center. And as we know more, certainly feel free to come back and talk to us, because we appreciate the larger picture, and I know that that it's a perspective we don't have. So.
Well, I'm happy to, and thanks. Loren's quite well informed, so I appreciate him being on the call as well.